Good morning from our team. We are going to continue now with the front transparent bit, which is the cornea. And it is a very, very important part of the eye, not only because it's an optical element. It is very important because of the stem cells that are in the limbus. Because more and more we study, more and more we understand that the health of the limbus is actually the basis for the health of the ocular surface. And some of us just came from ARVO, and there were lots of papers regarding the limbo stem cells. So in the next hour we are going to talk about the cornea and the opportunity to keep the health of the cornea in case of aniridia. And I would like to ask my co-chair Miriam to announce the first speaker.
So we will start with Keratopathy in Aniridia, clinical features and treatment options, that will be given by Dr. Branka Samolov and Per Montan from St. Erik Eye Hospital in Sweden. Thanks so much.
Thank you. I have no financial interests. Well, looking at this picture, one could wonder if anything has been done to this cornea or not. If the answer is no, maybe you would wonder, shouldn't it? And if the answer is yes, did it make any benefit? I think this picture really nicely illustrates the problems and dilemmas that we face when we meet the patients with aniridia. And as we lack the treatment for the cause of the problems, and still only have the treatments that patch and repair partially the problems that the patient have, the solutions will only be temporarily. And actually I could sit down now and let my three colleagues present clinical results as well. But I'll tell something more, and that's not only to repeat the things that have been spoken about previously, but also to underline that even when we evaluate one part of the eye, one should always think about the whole. So this rare pannacular disorder originates in the PAX6 gene that codes for a transcriptional regulatory protein that is a key player for the ocular and neurologic development, and also have the role in pancreatic development, as you know. The gene is placed on the short arm of the chromosome 11, and the inherited mutation or deletion of the regulatory regions that is inherited by a dominant pattern counts for two-thirds of the patients, and then one-third is affected by sporadic de novo mutations as well. Isolated aniridia, or should we say predominantly panocular problems, are the largest group, but there are systemic disorders that we know quite a lot about. Gillespie syndrome, as previously named, where the aniridia is accompanied by intellectual disability and cerebral ataxia, have the autosomal recessive inheritance and accounts for 2% of the cases. Eyes, this is in these patients you can see this pathognomonic sign of dilated and fixed pupils due to circular pupillary iris atrophy. And then Wegener syndrome is also named with the Wilms tumor and the genitourinary problems besides the intellectual disability, and aniridia accounts for 1/4 to 1/3 of the patients. Severe visual impairment, as Dominic so nicely said, or outlined, the name of the disease puts the focus on the anterior segment, while actually the retinal or neurologic impairment in the eye and retinal development is actually the key player, and the explanation for the severe visual impairment is there with the macular hyperplasia and in many cases also the optic nerve hyperplasia. And this shouldn't be forgotten when we look at the cornea and think if we can improve vision by doing something there. Iris, of course, well, actually, it's almost we've seen some of the cases where the iris is not that severely affected, but the cases the thing is actually that the iris is basically almost never completely absent. Even it can be really hard to see. So the name is misleading in this aspect as well. The problems in the anterior segment or angle will lead to the problems with the iris, with the intraocular pressure, with the high risk of glaucoma. Cornea affected in at least 80% of the patients, maybe almost 100, and it's more the matter of the extent and also when we evaluate the patient. The lens, almost always some kind of opacity already congenitally, and then the cataract involves, and the lens can usually also, not seldom, is also displaced. And then here comes the other symptom that we usually evaluate and think about when we look at the cornea and the patient need us or urges us to do something about it, and then the photophobia and the severe visual impairment are usually the ones that we take into consideration. And one should not forget that the cornea is not the only cause, regardless of how it looks. It's not the only cause of these two major problems. So limbal stem cell deficiency are central, as we know, but there is also abnormal epithelial differentiation and cell adhesion. The innervation is affected. There is elevation of apoptosis in keratocytes or increase. Alterations on inflammatory response, where the alteration in important enzymes will allow for the accumulation of fibrosis in inflammatory cells, and there is alteration of inflammatory response and also impaired tear production and altered tear composition. And all this will lead to vascularization, conjunctivalization, and in many cases thick fibrovascular pannus, decreased transparency, cloudiness that might evolve to dense opacification, and the changes start peripherally and superficially, and then progress more deeply and centrally. There is a decreased sensibility and appear impaired healing properties that, of course, are of a major impact on photophobia, but also the pain that we heard a lot about yesterday. Furthermore, the changes worsen with age. Biotopical medicaments where the preservatives should be avoided by any cost, and then of course they worsen by any surgical manipulation. So what can we do? To start with and never stop with the care of the ocular surface, so lubricate. Therapeutic contact lenses can be used in the same aspect or with the same goal, and they can both alleviate but also jeopardize this sensitive ocular surface, and the scleral lenses can be extra sensitive for the limbal area, so one should keep that in mind. Glaucoma control is not only important for the disc but also for the cornea status, and the drops should be preservative free. And then of course the patient needs a proper information. Not all patients with the same disease are the same, and not both eyes of the one patient are the same, usually not actually. And then of course the time point for possible surgery should be really wisely chosen, because even the best methods with uncomplicated course will have transient effect, and you will hear about this more of through my colleagues. But what can we do surgically? Well, keratoplasty only doesn't work. We learned that the hard way. Eccentric corneal transplant, including some stem cells, is better. Allogeneic limbal stem cells transplant will include more of the limbal stem cells, and it can be combined with the keratoplasty afterwards. And then for the very, very severe cases, very severe bilateral engagement of the corneas, there is a keratoprosthesis. Eccentric stem cells, including penetrating keratoplasty, has the advantage of systemic immunosuppression not being obligatory, especially if the transplant is HLA or immunologically chosen to suit the recipient. This treatment addresses both stem cell deficiency and the decreased transparency of the cornea. And the own stem cells, even if they are scarce and not working too good, they are still they are not disturbed by this kind of treatment. On the negative side, this will give us a limited source of the stem cells and endothelial cells that always age more rapidly in a recipient patient. And then, of course, we have the usual penetrating keratoplasty flip sides, but in a more sensitive setting. And these are the problems with the sutures, with the epithelial healing, with infection, inflammation, rejection, and of course the limited lifespan of the transplant. And then, of course, this can induce need for lens and glaucoma surgery. And in the cases where the lens or glaucoma surgery have already been performed, then the results after those can be changed or jeopardized by the keratoplasty. Allogeneic stem cell transplantation will probably give a better source of these stem cells, and one can either go with a livingly related donor that is best if it is immunologically matched. And then there is also a possibility of allogeneic keratolimbal graft, cadaveric, which gives us a better availability. On the negative side, one has to have a systemic immunosuppression as long as possible, probably lifelong for the best result. And one should remember that these are drugs with a severe side effects that in certain circumstances can actually be life-threatening. And then this method does not address already present corneal clouding, but can of course be combined with a keratoplasty afterwards. And then even here we have a limited source of stem cells, so the effect will be transient even here. And at the end there is a keratoprosthesis where we have the artificial optics that is combined with either the artificial or biological scaffold. Boston K-Pro, artificial one. The good thing is that the experience, it is not a big deal for an experienced corneal surgeon to perform this kind of a surgery. Osteoodontokeratoprosthesis, where the optics is held and fixated by the biological tissue, teeth, is a bit harder. It works even for a dry eye, even if dryness in these patients is not the critical one. On the negative side, this is a major surgical intervention which includes lens and glaucoma surgery. It can it can improve the visual acuity to some extent, but to the limited visual field. It's cosmetically not appealing. It has a high rate of severe complications that may lead not only to the loss of vision, but also to the loss of the organ, eye. And it demands meticulous controls by experienced and dedicated subspecialty team. And now a colleague of mine, Per Montan, will actually illustrate this by patients our own for each of these methods, I think.
Thank you. So I will illustrate what my boss just said, and we can leave the questions till afterwards. Yes, this is mine. So, surgical interventions for aniridia keratopathy. Yes. Okay. So, these are the principles, because we just learned whatever success we achieve, it's temporary. So, operate only patients with poor vision. Now, what is poor vision in this context? Well, the actual vision potential of the patients that we have operated have not been beyond 0.1 or 0.2. So this means that if a patient sees anywhere better than finger count 3 meters, we don't operate them. And focus on one eye only. If the procedure is not successful, go for a redo, try again with another method or repeat the method. And vice versa, if you're successful, don't get tempted to operate the other eye, because you really need to have one in reserve for a rainy day, so to speak. Have I done this mistake? Yes, I have sinned. I have operated the other eye, inspired by a happy patient. Don't do this. And finally, don't forget, there is glaucoma around, even from the outset of your surgery, and it gets worse by your surgery. So I will give you some case stories that illustrate all this, trying different methods. And this is actually an image of a classical penetrating keratoplasty, which we consider as a second-rate surgical intervention because it does not address the limbal stem cell deficiency. But I must say, in some cases, the cornea stays clear, which is not logical, for years, and it has served the patients well in some instances, but we avoid this in modern times. So case one, a 45-year-old patient had surgery in her right cornea already at 20 years of age, and this I meet her about 20 years later. So glaucoma surgery was performed in both eyes. You already saw this image. I think it was the first that Branka showed. So this is the eye with the PKP, which has failed, of course. And so what was the solution here, so to speak? Well, I tried this eccentric PKP, which means it adds then limbal stem cells. And also she had a cataract, so she had an open sky extracapsular cataract extraction, and turned out that she gained 0.1 vision. This is 2 years down the road, and her doctor referred her because she was worried about this pannus ingrowth that you see over here. I cannot point to all the screens, unfortunately. Anyway, is this something of concern? Well, it depends on how the central cornea is, and it still maintains clarity. So she was still having 0.1 vision, and you shouldn't really bother about this ingrowth as long as the graft is functioning. So I was just happy to see that she was still seeing very well, and this pannus is part of the game, so to speak. But as long as it doesn't cover the entire surface, it's okay. But eventually, the entire cornea was invaded. So there was a redo, a third PKP, this time also eccentric. And I saw her the other day. And the vision was once again 0.1, which is not bad, but she was not happy. So what had happened in the meantime? Well, her glaucoma worsened, so she had a very poor visual field in this eye. And she's not inclined to have immunosuppression, so what to do? Well, she wants to have surgery in the other eye, which has not been touched. And in a way, it's a gold mine of opportunities because, as I said, the cornea was never touched. There's also cataract that can be removed. So, of course, we could try the same procedure that the other eye was subjected to 10 years ago, roughly. But the jury is still out. I haven't made up my mind, of course, because she's still seeing in the other eye, and she's 55 years of age, and the life expectancy would be 25 more years. So it's not an easy decision. So I don't know what to do. But the patient is waiting for an answer. Now, leaving the cornea itself, let's look at the stem cell niche and what we can do. Branka mentioned keratolimbal allografts. It's a wonderful idea. Actually, it works. It's a tedious surgery. I will show you some images later on. But you actually do not touch the cornea, say for the scraping of the pannus, but you work on the surface with these annual donated rings. This is a patient who luckily had a healthy mother who donated then slight limbal tissues that were taken from the 12 and the 6 o'clock position and moved over to the recipient eye. So when we do this, Branka is taking the limbal tissue. It's a very delicate procedure, and I then put the limbal explants in place. In the recipient eye, I think you can guess where here you can see the tissue implanted with sutures. And this area of the cornea is quite clear, even though it's not very neatly shown in this picture. Anyway, she got a swift vision recovery, very happy. But 3 months after the procedure, there was a rejection. And how can you see this? Well, the central cornea, or the inferior part of the cornea, is covered with phenotypically correct cells, but what is stained in green is a metaplastic area where the correct phenotype is simply not there. So these two explants did not suffice to restore a clear cornea. So there were, at any rate, there were 2 redos where the original plan then was left. We couldn't really use this living-related tissue. She was given cadaveric tissue instead. But with these re-interventions, the visual acuity stayed at 0.1. She was under immunosuppression for all these 5 years, but then the stem cell pool was depleted and vision was worse. I tried a 3rd annual limbal graft, didn't work, waited for some time, and then the patient was provided with an HLA-matched eccentric PKP. She's still under immunosuppression. The vision was back to 0.1, but now, a year later, she has a rejection. So what to do next? Well, the jury is still out. I haven't made up my mind, and neither has she. And I think Branka will deal with this rejection this summer, but still the same eye. Still the same eye we're working on. So the other one is still there for future interventions. Age right now 45. Case 3, am I running out of time or? Okay, a similar case. Unfortunately, only one eye left. I had to perform cyclodiode laser for a bad glaucoma in this eye, and we decided to try limbal grafts, also this time from a living related donor and an HLA identical brother, which is very fortunate. This is right after the surgery. This is 3 years down the road. She did not need supplementary material. This was enough to restore a clear central cornea. And it worked for another 3 years. So after 6 years, the eye unfortunately went phthisic. It means that she lost all pressure in the eye. Probably, well, it could be because of the disease itself, but probably also because of the cyclodiode laser treatment, which is tricky in the long run. And unfortunately, she became blind. Boston K Pro, very ingenious technique where you implant an artificial optic, which cannot be rejected, but it's still a risky business. This patient consented to my showing the picture of her. It's an eye which had gone through previous surgeries, glaucoma, cataract, and also keratolimbar allografts, and we opted for a Boston K Pro implantation. Fantastic vision with a telescope. She's a very optimistic patient. Unfortunately, the glaucoma worsened. We had a tube implant 2 years later, and 2 years later than that, that is 4 years after the implantation, there was a retinal detachment, which is a known complication. It was not discovered in time, and the eye was lost. And we've had close contact since then. The other eye is still there, and now the vision is below 0.1, and she wants surgery. She's 84 years old, of course, so the expected life span that she, well, the life expectancy is not that long. She wants a K Pro again. I'm not sure I want to give her one. Final case, I haven't made up my mind. Final case, a patient 65 years at the time had a keratolimbar allograft that didn't work. So we tried a Boston K Pro together with shunt surgery. And it's a happy case because this is now 11 years later and the K Pro is in place, providing the patient with 0.1 vision. But of course, we don't know in the long run. So these are just a few words about what the literature says about these different methods. Eccentric PKP, it's the most convenient technique, but it's a little bit worse, I must say, than the others. A 3.2-year expectancy for graft survival. The keratolimbar, good vision up to 3 years, and then afterwards it's debatable. I think the results are better now because this is an old paper from Cincinnati. And Cincinnati is it's an acclaimed center of aniridia treatment. And the K Pro shows a little bit better in terms of longevity of the procedure. So thank you for your attention.